Hello, everyone, and thank you for joining us. We're super excited for tonight's topic that discusses the use of sodium hypochlorite in dentistry. Before we get started, there's just a few things to mention. So first, if you have questions, type them into the question box on the right-hand side of your screen. We'll have some time at the end for Q&A. If we run out of time, we'll get back to you by email. And if anyone wants to learn more, feel free to contact us to schedule a meeting with you and your team. With that out of the way, I'd like to introduce Dr. Kim Kutsch. He's the CEO and founder of Carifree. Dr. Kutsch has been successfully practicing dentistry for 35 years and still practices 3 days a week here in Albany, Oregon. And he's also the world's leading authority on ATP as it relates to caries risk assessment. All right, Dr. Kutsch, I'll let you go ahead and take it from here.
All right, thank you. And first, I want to thank everybody for being with us tonight. I'm always amazed and humbled by how many people attend this webinar series. It's been so popular, and the whole social media information evolves, and while webinars are tending to lose favor for a lot of companies, this webinar series continues to grow at alarming rates. So I really want to thank you, because I'm quite humbled by that. And I want to thank my team, because they always come up with topics that evidently are things that are very popular with you all. So I'd like to thank both of you all tonight. And we got a lot of material. This was really kind of a fun program for me to put together, going and looking at all of the current research on sodium hypochlorite. And I think you'll find it interesting. And sodium hypochlorite has really a long and storied history in the dental profession, and we use it a lot. And probably more than we actually even stop to think about. And so, we've been using it for dental caries, obviously, for the last 15 years. But we'll go through that topic and then a bunch of those, share some of my research that I did. That'll be review for some of you, and then, the current research which is out there. So it's very interesting. I wanted to share this with you first, because one of the things that, we continue to work on as a profession is, the oral health issues, and oral conditions remain like the #1 public health challenge of the 292 diseases that the World Health Organization tracks. Dental caries is #1, and it, in spite of all the things that we've done in our profession globally, we're still #1. And if you look at this graph right here, those are all oral conditions, and then they rank them by globally, and then also high socioeconomic, demographic, mid, and low. And the top two bars, the light blue, and then the one below it that's kind of navy blue, those are deciduous caries and dental caries in permanent teeth. I mean, they make up 70 to 80% of the dental or the oral health conditions, diseases. I mean, this is still like the biggest disease that you and I treat in dentistry, and this is true globally, and it's across all economic demographics as well. So dental caries is still a huge issue, and I think we're making real inroads into that, at least all of us individually in our profession. But as societies, we still have a long ways to go. But the oral health burden from dental caries is still #1, and it's still huge. One of the things that I first looked at when I got involved in this almost 20 years ago was an antimicrobial approach to the biofilm disease that causes dental caries. And so that's where my whole interest was. And I started with, I'd been using, Listerine with my patients, or other mouth rinses, and then I switched to the Featherstone model using chlorhexidine. I used chlorhexidine for a couple of years. I wasn't happy with the results I saw clinically. I was culturing both mutant streptococci and lactobacillus in those days, and I could get rid of the mutant streptococci with chlorhexidine, but then the patients would come back with a full, tab full of lactobacillus, and that really concerned me. So then I switched to betadine for a year, and I have to tell you that betadine as a mouth rinse is very problematic, and it tends to work well in children, although it's not tolerated by children, and it's not really tolerated well by adults, and the data we have on that with adults wasn't very impressive either. And so then I switched to sodium hypochlorite. There was a lot of expansion of the use of sodium hypochlorite, particularly by Jorgen Slotz, and in the periodontal side of things. And just looking at some of that research got me interested in trying sodium hypochlorite. And so obviously we developed a rinse around that, and I've been using that ever since. I think one of the papers early on that they wrote, the Slots and his group wrote, was really that we've been using sodium hypochlorite, I mean, in dentistry, and we use it in nursing homes. We use it everywhere as a disinfectant. We've been using it for 100 years this way. And of course, we use it in root canals. We've been using it as an irrigant in root canals for a long time as well, almost 100 years. And so we have a long history of using sodium hypochlorite. And the interesting thing about it, it kills everything. It pretty much kills everything on contact. It doesn't create any adverse reactions, and it doesn't create any persisters. So, you know, it kills microbes without creating persistent or adverse issues with it. So it's a safe, effective antimicrobial agent. The biggest challenge is it tastes like household bleach. So, you know, that's probably the biggest challenge that we have with it. But it has a broader spectrum of antimicrobial action. And so we initiated a study in Queensland, Australia back in 2007. It was a 3-year clinical trial. We looked at, in the small town of Townsville, we looked at 2 public schools. So these were grade school children, mixed dentition, and they were both high risk. This community is non-fluoridated, and so these were really high risk kids. All of them, literally in these 2 school groups, were high risk. And one school, we treated them once a day with a supervised oral rinse with just a 0.05% fluoride rinse, and they rinsed for 30 seconds, and they go to school there 4 days a week, 9 months out of the year. And in the other group, we used the treatment rinse, the sodium hypochlorite, 0.05% fluoride. And in the group with the sodium hypochlorite, we saw a 73% reduction in their decay over a period of 3 years. The one school we saw, which is pretty typical with 0.05% fluoride, and most fluoride studies or chlorhexidine studies, you see somewhere around a 28 to 30, and those are really consistent numbers. And so that's real valid data. That's typical. That's what you always see. You know, I think fluoride in water, the CDC estimates reduces the decay rate in Americans by 27% per year. So, you know, we saw a decay rate decrease, you know, in the magnitude that you would expect. Interestingly enough, in the group that was using the treatment rinse, we cut their decay rate in half the first year and cut it almost in half again the second year, and for a total reduction of 73%. And I got to tell you, that's off the charts for looking at an antimicrobial approach to treating dental caries. A number of papers on this particular study have been published. I think 3 papers have been published so far off of this data, but that was very impressive. But the interesting thing to note was that we saw that reduction in year 1. Again, we saw a significant reduction in year 2, but in year 3, it didn't seem to be any continued improvement. So, you know, as we look at, well, how long would you put a patient on an antimicrobial agent like this? Well, based on this one particular set of data, you could expect continued improvement for a couple of years, but after that, you're probably going to get all the improvement out of that you're going to. So we reduced it in half and almost by half again. So one of the other things that I did through the Forsyth Institute at Harvard University, I did some DNA checkerboarding. So I took 5 high-risk caries patients, and I took plaque samples, and then I had them use the treatment rinse twice a day for 60 seconds for a month. And so I did a checkerboard before, and then I did a checkerboard after. And at that time, so this was about 10 years ago, at that time we looked at 448 known oral bacteria in the mouth. And what we found was that we eliminated the mutant streptococci and reduced the lactobacillus, and then we had an increase in what we would have, at that time, I certainly would have termed as kind of commensal healthy bacteria. We saw an increase in capnocytes. These are just garden variety bacteria that we don't believe are really pathogenic. So Granuloticacella, Lepitricia, you know, Actinomyces, Vianella. I mean, so we felt pretty good about that. And at that point in time, 10 years ago, I probably looked at dental caries as a more microbe-specific kind of infectious disease. And today I really look at it as biofilm dysfunction, and we know based on all of Takahashi and Nevad's papers that they published over the last 10 years that it's really, these players can become bad bacteria. They can behave badly, like literally after 30 minutes of being exposed to an acidic environment. So it's really a function more of what's the biofilm, what's the bacterial load, how is the biofilm behaving, really, rather than looking at individual microbes. But the one thing that we know is if we can reduce that overall burden of the biofilm in the mouth, certainly we've got a chance to improve our situation in dental caries. So the papers kind of break into how we use sodium hypochlorite in dentistry, and so I wanted to start with some of the perio studies because that's where most of the research had been done on that. And again, this was a pilot study, and again, it was Jorgen Slotz was involved in this. They had 30 patients that had periodontal disease. Half of them got a rinse and a twice weekly irrigation with subgingival irrigation with 0.25% sodium hypochlorite, and half of them got distilled water. They were examined at 0, 2 weeks, and 3 months. And at the end of this, there was a marked decrease in plaque and bleeding on probing in the patients that were in the sodium hypochlorite group. So it really kind of pointed to the effectiveness of sodium hypochlorite as an antimicrobial agent, and really kind of, I think, initiated a lot of the research that's been done on sodium hypochlorite. And then in this study, 2.5% sodium hypochlorite was used, and these were root canal biofilms. But I included this because it really, I think it's an important study from the standpoint that it significantly, sodium hypochlorite significantly dissolves the biofilm matrix. And so in this study, they took 28 human dentin samples, they inoculated them with root canal biofilms, and they cultured them for 28 days. So these were mature biofilms. And then they exposed them to 3 minutes under confocal laser scanning microscopy. And the 2.5% sodium, so 2.5% sodium hypochlorite actually dissolved the biofilm matrix. It kills the bacteria significantly, and is actually more efficient than the other agents that were tested, like chlorhexidine and alexidine, when used against mature biofilms. And this was actually a slide of an in situ study. This is a biofilm that's been dissolved. That was in situ, and Graham Milisich did this work with us about 10 years ago as well. So we know that sodium hypochlorite disrupts proteins, it dissolves the biofilm matrix, and it kills the microbes. So there's some advantages to sodium hypochlorite there. In this next study, again, 30 patients with periodontitis. It was a 3-month study, and it was performed. It was a randomized, controlled, single-blinded clinical trial. And again, 2 parallel groups. 15 patients rinsed for 30 seconds with 15 mils of 0.25% sodium hypochlorite, and 15 patients rinsed with 15 mils of water as the control. So again, they were examined at baseline at 2 weeks and again at 3 months. And at no time during the study did any of the patients receive they didn't receive any scaling or root planing, but they did receive professional subgingival irrigation for 5 minutes with either the sodium hypochlorite or water. But there was, like I said, there was no scaling. And at the end of 3 months, again, the sodium hypochlorite group had a significant difference in terms of plaque, dental plaque, and bleeding on probing. So again, this points to sodium hypochlorite as an encouraging antimicrobial agent in terms of plaque reduction in the mouth. So I think that that's significant for us. And then this study was performed as was actually a review. And this was a review paper, and again, Slotz's group looked at a bunch of papers, and their conclusion was twice weekly oral rinsing with dilute bleach of 0.25% sodium hypochlorite produced a significant reduction in bleeding on probing, even in deep, again, like none of these pockets had any scaling or root planing. And it represents a really important or valuable antiseptic in patient self-care. And this paper, again, reviewed the sodium hypochlorite clinical studies and the efficacy again. Again, this is Jorgen Slot, so I know there's some possibility of bias because we're looking at a lot of the same authors writing a lot of papers. But again, they're using a lot of different data in those papers, and so in this review again, sodium hypochlorite twice a week with dilute bleach is a valuable adjunct in patient self-care, particularly in reducing dental plaque and gingival inflammation. This next study, actually, one of the questions, I think, because that we know that sodium hypochlorite does dissolve proteins, does dissolve the biofilm matrix, is it safe to use, the question was raised, is it safe to use as a subgingival irrigant? Is it going to delay healing, or is it going to interfere with fibroblasts and epithelial migration? So the aim of this study was to look at the histometric effects of subgingival irrigation with different solutions, and they did this in rats. So they created periodontal disease was induced by ligature wires in the first lower molars of 91 Wistar rats over the course of 28 days, and they removed the ligatures, and then they did scaling and root planing, and then they followed that with subgingival irrigation with different solutions. They used 0.9% saline, 0.2% chlorhexidine, 0.1 and 0.5% sodium hypochlorite, and 11% propolis extract. And what the difference was, there was actually, the results were, there was no difference statistically between the groups treated with the scaling and root planing and the groups treated with subgingival irrigation regarding the amount of bone support or the epithelial migration. And also, there was no significant differences found among the different solutions for subgingival irrigation. So there was no histologic difference between 0.9% saline or the 0.1 or 0.5% sodium hypochlorite or the 0.2% chlorhexidine. So the conclusion of this study, which was published in January 2016, is from a histometric standpoint, subgingival irrigation with sodium hypochlorite is safe and effective. This next study then looked at, took 6 representative periodontitis-associated bacterial strains. They were grown for 24 hours under anaerobic conditions, and after mixing the individual cell pellets, they were exposed to 10 different antiseptic mouth rinse formulations. And so they looked at chlorhexidine at 0.2 and 0.06. They looked at chlorhexidine plus cetylpyridium chloride at 0.05. They looked at sodium hypochlorite at 0.05%. They looked at polyhexanidine at 0.04 and a 0.1, octinidine, dihydrochloride at 0.1, fluoride at 250 parts per million, essential oils, povidone iodine, and saline as the control. And basically, the best combination of this was the chlorhexidine in terms of bacterial inhibition at 0.2%. But I would tell you, you know, this is not a level playing field. I mean, I don't know who funded this study, but they only used a 0.05% sodium hypochlorite. And I would think that had there been a certainly a 0.25% or 0.20% sodium hypochlorite and a 0.12% chlorhexidine, we might have seen a different result. So I included a study, but I think that there was obviously some bias in the study based on how the study was set up. So the study design there, I think, is a problem for me. The next study was a randomized clinical trial of 4 groups. 110 chronic periodontitis patients received basic periodontal therapy plus local irrigation with saline or local irrigation and disinfection with sodium hypochlorite. And then they also did the basic periodontal therapy along with the sodium hypochlorite and antibiotic therapy, which included amoxicillin and metronidazole. And then they did basic periodontal therapy plus saline plus amoxicillin. The outcome was analyzed at baseline, 3, 6, and 12 months. And the short term, there was better outcomes in the terms of pocket depths with the group that did the scaling and root planing plus sodium hypochlorite plus the antibiotics. But at 1 year, there was no microbiological difference between any of the groups. So, but the one thing you have to understand in the study is that, yeah, so the sodium hypochlorite performed best immediately in terms of outcomes, but at 1 year there wasn't any difference in outcomes. But this was a one-time treatment. So to be able to use an antimicrobial agent or antibiotics and just use it one time and then look at things a year later, I guess I really wouldn't expect a huge difference in outcome whether you use saline, water, sodium hypochlorite, along with the basic periodontal therapy. So it did have value in the short term, which I think is encouraging. But I think that obviously Slotza's work indicates you should use it as a rinse at least twice a week. So that's again, and there's a design study there that I question. In this next study, this was an interesting study. They looked at how do we get the periodontal ligament fibers off of the root if you're doing kind of an immediate reimplantation, and versus being able to salvage this, save the cementum, disinfect the root and get rid of these periodontal ligament fibers. And so they took 35 roots of healthy right mandibular first premolars that were extracted for orthodontic purposes. They kept them at room temperature for an hour and then divided them into 5 groups. So they had a control group. They had one group with mechanical removal of PDL, and then they had a chemical removal by immersing the root in 1% sodium hypochlorite for 5 minutes, 2% sodium hypochlorite for 5 minutes, and 1% sodium hypochlorite for 10 minutes. And then they were looked at histologically and examined under SEM. Sodium hypochlorite solution had the ability to clean up the periodontal ligament remnants, but it preserved the cementum layer at the same time. So they really determined that this might be the ideal choice of how you would treat this tooth before you would replant it. If somebody avulsed a permanent tooth and you were trying to replant it. So I thought that was interesting. I'd never really considered using sodium hypochlorite in this situation, but it looks like the best of all of the alternatives. The next study looked at sodium hypochlorite gel and its components of sodium hypochlorite, and the activating vehicle was compared to 0.1% chlorhexidine. The antimicrobial activity was proven by minimal inhibitory concentrations and minimal bactericidal concentrations and killing assays. The influence on formation as well as a 4-day-old 6-species biofilm was tested. So they were looking at 4-day-old biofilms that were multi-species, and the sodium hypochlorite gel works really well, particularly against gram-negative species associated with periodontitis, and it was also able to alter the biofilm matrices, which we've known previously. So sodium hypochlorite gel certainly has a potential to use in terms of treating periodontal disease as well versus chlorhexidine at 0.1%. The next study was looking at different volumes of sodium hypochlorite, and they were added to either chlorhexidine or parachloroaniline, and both other antimicrobial agents. And when they looked at a bunch of studies on this particular topic, like can we mix these different antimicrobial agents, what they found was the data was kind of all over the board. And really their conclusion was that chlorhexidine and sodium hypochlorite has a wide range of cytotoxic effects, and it's really, even with the PCA, it was kind of the data was just literally all over the board, and the PCA is probably not stable in the presence of sodium hypochlorite. And so the conclusion here is, you can use these antimicrobial agents, but don't mix them. Like, I don't think it's a good idea to mix sodium hypochlorite with parachloroaniline or chlorhexidine. So that's kind of the message of this study. The next study, again, is a review, and this is Jorgen Slotz, and this was published this month, literally. And again, just writing that, patient self-care is a critical part of periodontal health care, and again, twice weekly oral rinsing with 0.1 to 0.25% sodium hypochlorite is a valuable anti-plaque and anti-gingivitis treatment. And in this study, microbial samples were collected with periodontal curettes from 3 to 12 millimeter deep pockets, and then they were examined at baseline and at 2 weeks and at 3 months. And so they actually, again, sodium hypochlorite was part of one of the test strategies in terms of looking at the improvement of periodontal, microbe, the communities, the biofilm in the pocket. And one of the things that was interesting about that, I included a study, I thought it was interesting, was that the patients that had, following the therapy, that had a stable biofilm actually had better improvement in terms of the periodontal health and recovery than the patients who had less stable biofilms. So they had a lot greater diversity of microbes in that biofilm, and it was less stable, and they actually did not respond as well to any of the therapies. So their point was, at some point in time, we need to look at maybe, a multi-omics or a metabolomic analysis in particular to be able to predict which patients are going to respond to therapy better than others. But I thought that was kind of an interest. I'd not seen any data like this published before. But again, in this study, they were using 0.25% sodium hypochlorite along with other basic periodontal therapies. And that kind of is the gamut of the periodontal studies. I know Jorgen Slotz has played a major role in there. I tried to include as many studies other than his group as well, just to try and reduce, certainly the bias from just having the same group of authors doing the same studies over and over and over, and kind of reproducing that data. And in endodontics, we have used sodium hypochlorite for, like I say, almost 100 years, and it's a safe, effective antimicrobial agent in terms of disinfecting, prepared canals. So there's been a number of studies published just recently. Again, this one was from 2016 at the end of the year. And in this study, and in many of the endodontic studies, we look at Enterococcus, fecalis. That's the bug that we always look at, or primarily look at in terms of, failing root canal or root canal infections. So in this study, they used 4, 6, and 10-week-old biofilms of E. fecalis, and they were subjected to one of the following approaches. They were either used a buffered saline solution, or 1, 2.5, or 5% sodium hypochlorite. And the 2.5 and 5% sodium hypochlorite completely eliminated the Enterococcus fecalis biofilms in all 3 stages of the biofilm development. So whether it's 4, 6, or 10-week-old, the sodium hypochlorite completely eliminated them, whereas the 1% sodium hypochlorite had reduction rates of 86, 82, and 79% in the 4, 6, and 10-week-old biofilms, which is significantly better than the phosphate buffered saline solution, which you would expect. But so it looks like in root canal systems, we really need to be using a concentration of at least 2.5%, and I know a lot of the preparations that we buy and we're using commercially are 5.25%, but it's very effective as an antimicrobial agent, in the canal. This was another endodontic study, and this was an in vitro study that compared 2.5% sodium hypochlorite gel and 2.5% and 5.25% sodium hypochlorite solutions on, again, Enterococcus fecalis biofilms. So the root canals of 60 extracted human teeth were incubated with E. fecalis for 6 weeks. Then they were exposed to 5 milliliters of each irrigant. Samples were collected, and there was a 1 to 10 serial dilution, and added to Mueller-Hinton auger plates and incubated for 37 degrees for 48 hours. And then a classic colony counting technique was used to determine the vital E. fecalis bacterial counts. And the bactericidal effect of all irrigants in all 3 experimental groups was significantly greater than the control group, which you'd expect. But there was no significant difference between the 2.5% and 5% sodium hypochlorite solution, but they were both significantly better than the 2.5 sodium hypochlorite gel. So, I guess the message here is that while we had a study that looked favorable in periodontics using a 2.5% and you can't really use a 5% sodium hypochlorite. I wouldn't recommend that as an irrigant, but a 2.5% gel seemed to be safe and pretty effective in treating periodontal disease or gingivitis. Inside of a root canal, we really need to be using a liquid as an irrigant and need to be in the at least 2.5 and 5%. That's consistent with the last study where the 1% sodium hypochlorite just wasn't as effective. In this next study that was published in 2016, so this was a study that looked at a laser, so photo-activated disinfection. And so again, they took the root canals of 60 maxillary central incisors were contaminated with E. faecalis, and then the bacteria were incubated for 24 hours. All the root canals were instrumented in a crown-down manner with a number 4 and number 3 Gates Glidden drills, followed by rotary files. In the photo-activated disinfection group, the laser was used, so this is a diode laser with an output of 100 milliwatts per centimeter squared for 120 seconds, which is essentially 2 minutes. And I have to tell you, a continuous wave diode at 100 milliwatts for 2 minutes is I would not recommend doing that in a root canal, in a canal system. That's a pretty hot, it doesn't sound maybe like all that, but you take 100 milliwatt and you cannot hold that on your skin for 2 seconds. So to put it in a canal for 120 seconds, that's a diode laser used at pretty serious parameters. And in the other 2 experimental groups, the root canals were irrigated either with 5 mils of 2% chlorhexidine or 2.5% sodium hypochlorite solution. And in the study, the results of the study was that 2.5% sodium hypochlorite was significantly better than either the laser, the diode laser, or the 2% chlorhexidine. And again, I would not recommend using a diode laser in a canal at 100 milliwatts for 2 minutes. I don't know that anybody is recommending or doing that. The study came out of Iran, but I found those parameters to be quite interesting. This was an interesting study because one of the challenges that we have in root canal systems is I was just reading I think it was Cliff Ruddle today, a paper on looking at the suddenly we're starting to take a greater appreciation because we can now, particularly with cone beam technology and our preparation technology and our cements in the root canal systems and continuous flow gutta percha, resin cements. You go through, our technology is changing in terms of endodontics, and we're starting to appreciate that these canals are not just conical in shape, and there's a lot of ribbons and accessory canals, and there's a third dimension here that's a lot more complex in this system than we probably have known for forever, but we probably haven't been able to treat it or examine it very well, so we tended to do the best that we could with the technology that we had at the time. I wouldn't say we ignored it, we were just limited in our abilities. And so this was a study that looked at 68 mandibular molars with a normal pulp were extracted for periodontal reasons, and then they were assessed for the presence of an isthmus using cone beam technology, and the root canals were included in the molars were instrumented to a ProTaper F2 using a 3% sodium hypochlorite irrigant with apical negative pressure and a continuous warm activated irrigation and evacuation system, which is kind of new to have this continue flowing irrigation while you are doing the ProTaper, the rotary instrumentation. Interestingly, none of the systems removed all the remaining pulp tissue when they sectioned and looked at these teeth from the isthmus, but the continuous warm activated irrigation with sodium hypochlorite performed the best out of all the, and we know that, again, you probably would expect that because of the fact that it, disrupts biofilm, the protein matrix, and, it disrupts proteins. So the result of the study here was, this is a new technique, and we may see more of this, I think, and development of this in the future as we look at endodontics. The next study compared tetraacetyl diamine sodium perborate at 5% and compared it with 5% and 2.5% sodium hypochlorite. And again, they placed these on 3 discs. They inoculated 60 plates of Mueller hen auger culture medium with E. faecalis, and they incubated them for 24 hours, and then they looked at the diameter of the inhibition zone around the disc using a transparent ruler. And the sodium perborate and 5% sodium hypochlorite have similar antibacterial activity. However, the sodium perborate was better than the 2.5% sodium hypochlorite. So I think if you want the most effective antimicrobial, antibacterial effect as an irrigant in a root canal system, it probably is the 5 or 5.25% sodium hypochlorite. Now, then we take that 5% sodium hypochlorite, or 5.25% sodium hypochlorite, and we know that it disrupts the dentin matrix, and it may affect the bond strength as we're trying to use adhesive systems, certainly to build up these endodontically treated teeth. So this was a study then that took 90 human premolars, prepared dentin. They were treated with nothing, or they were treated with 5.25% sodium hypochlorite for 10 minutes, with or without sodium ascorbate for an additional 10 minutes. So I don't know anybody that's using 5.25% sodium hypochlorite as an irrigant for 10 minutes in a canal system. I mean, we're using it off and on and rinsing the canal and instrumenting, but I don't know that any of us are using that for, leaving it sit for 10 continuous minutes, but that's what they did in the study. So this is pretty much an extreme look at our use of sodium hypochlorite, in my opinion. But interestingly enough, applying the sodium ascorbate increased the dentin bond strength back to normal dentin. So while we know that there's a decrease using 5.25% sodium hypochlorite in terms of bond strength, sodium ascorbate seemed to eliminate that effect, or mitigate it. So I think that you're probably going to look at that as a clinical product at some point in the future. I don't know if anybody is currently using that. This next paper, again, was a review paper looking at sodium hypochlorite as it's routinely used to irrigate endodontic canals, again, for its antibacterial action, proteolytic and dissolution capability, and debridement properties. However, again, we know that it can affect the dentin and, and alters the bond strength if we use it in higher concentrations, and it seems to be a time-related phenomenon as well. So I think that's just something for all of us to be aware of. In this study, they looked at, again, photodynamic therapy using a laser and comparing it with 2.5% sodium hypochlorite against E. faecalis in root canals using real-time PCR. So they took 60 human upper central incisors. The root canals were infected with E. faecalis, and then incubated for 24 hours. In the control group, they did nothing. And then they had one group with laser therapy, again with a power of 100 milliwatts with a diode laser for 120 seconds. And then the other third group was irrigated with 5 mils of 2.5% sodium hypochlorite. And the effect of the sodium hypochlorite was, in all the samples, was better than the photodynamic therapy. So the 2.5% sodium hypochlorite was better than the laser, which was better than the control. And again, I haven't had time to go look if that's a recommended protocol, somewhere in the world with a diode laser. But that's again, that parameter kind of concerns me. The next group, again, was another laser study, and this one they were using the erbium YAG laser along with sodium hypochlorite. And the laser erbium YAG was activated at 1 watt for 20 seconds. And again, this is a pulse laser, so it's significantly different than a continuous wave laser like you would see in the diode. The infected canals, they took extracted human teeth, they contaminated with Enterococcus faecalis for 4 weeks. So again, we have mature biofilm growing here. Then they were shaped to different apical terminal working widths, and then treated with either the erbium YAG plus sodium hypochlorite at 0.3 watts for 20 seconds, or sodium hypochlorite alone. And the erbium YAG plus sodium hypochlorite showed a higher disinfection rate at each apical terminal working length, or width, I'm sorry, compared to sodium hypochlorite alone. In fact, the best of the procedures, the number 15 terminal working width with the erbium YAG plus the sodium hypochlorite and with the laser at 1 watt for 20 seconds was the most promising of any of the protocols. So it certainly, either the erbium YAG or the erbium chromium YSGG, I know there's a lot of work that's been done with the water lays in terms of laser PIP. So we know that there's a lot of opportunity here, and I think you're going to see a lot of continued work in terms of using erbium lasers in endodontic therapy. In this next study was yet another laser study, and in this one they used an ND YAG laser. And again, this is a pulse laser. They took 60 single-rooted human mandibular teeth, and they were decornated to a standard length. The samples were then prepared by a race rotary system to a size 40. And in group 1, they irrigated with the EDTA, 17%, and then 5.25% sodium hypochlorite. In groups 2, 3, and 4, and then they did 1%, 2.5%, and 5% sodium hypochlorite that was activated with the ND YAG laser, respectively. So they had they looked at 5 different groups, and all the different concentrations of sodium hypochlorite activated with the laser had a positive effect on removing the smear layer. And the sodium hypochlorite activated with the laser removed the smear layer more effectively at the coronal and the middle third, however, than at the apical third. So again, sodium hypochlorite combined with a laser appears to be more effective than sodium hypochlorite by itself in terms of removing of the smear layer. In this study, then, they looked at, the question was asked, how does it affect the dentin? And how does it affect our bond strength to that dentin? So again, another question asked, and in this they looked at 60 dentin slabs, human dentin slabs, were taken from freshly extracted premolars. They were randomly distributed into 4 groups and treated with 1%, 5%, and 10% sodium hypochlorite, and then the control group with distilled water. They were treated for a total of 60 minutes, okay, which is a very long period of time in terms of what our clinical use would be. And then they used attenuated total reflection infrared spectroscopy, Raman spectroscopy, and X-ray diffraction. That was carried out pre-op, 10 minutes after, and 60 minutes after the 60-minute treatments. And then they also looked at SEM, and then the flexural strength tests were conducted after they bonded to the dentin as well. The results showed that the dentins experienced morphologic alteration, as you would expect in the sodium hypochlorite group, as it undermines the organic content, and it's done so in a time concentration dependent fashion. So it really, the higher the concentration and for a longer period of time, had the greatest influence on the flexural strength and the toughness of the dentin. And they said, additionally, an irrigation at the end of 1% sodium hypochlorite within 10 minutes can minimize the effects of sodium hypochlorite on the structural and mechanical properties of the dentin. So we've got 2 issues going on here. We've got to have a high enough concentration of sodium hypochlorite for bacterial disinfection and removal of the smear layer. At the same point in time, you got to balance that with the effect that it's going to have on the dentin, particularly if you're going to try and bond to it or use a resin cement. So there's a balance there, and it is a dose and time dependent equation. So I'll leave that with you. The 1% at 10 minutes seemed to minimize the effects, but certainly we know that 5.5% it has a greater efficiency in terms of disinfection. So that kind of concludes the endodontic studies, and those are just the most recent studies on sodium hypochlorite in endodontics, but again, we've been using it in endo for a very long period of time. I've got a couple of studies left here I want to share with you that I thought were quite interesting. And so these relate to, primary teeth and orthodontics, and then I also have a denture cleaning study right at the very end. So this study looked at indirect pulp capping, comparing, they were looking at long-term outcomes, so 24-month outcomes, looking at vital pulp therapy, the options of indirect pulp therapy, direct pulp capping, and pulpotomies after a minimum of 12 months to determine if one of these vital pulp therapies was superior to the rest. And the highest level of success came with the MTA and formicreosol in the treatment of deep caries in primary teeth at the end of 24 months. And the direct pulp capping showed similar results to the indirect pulp capping or the pulpotomies, but the quality of evidence was lower for that. And at the end, and they also used sodium hypochlorite as a agent in the pulpotomy. And at the end of 18 months, the sodium hypochlorite success rate was significantly less than formicreosol and less than also the MTA. So the message here is, sodium hypochlorite is a great effective antimicrobial agent. It doesn't take the place of formicreosol in a pulpotomy. So I don't know that anybody's doing that, but if, certainly I've used sodium hypochlorite to disinfect a direct pulp cap. And, I know a lot of people have used it, sodium hypochlorite in lower dilutions or lower concentrations as a disinfectant on dentin itself. But again, it's a time dose dependent, equation on how it's going to alter the surface of the dent and may affect your bond strength. But the message here is don't use sodium hypochlorite as a pulpotomy agent. This I thought was a really interesting study. So this involves orthodontics. And one of the challenges that orthodontists have is fluorose teeth tend not to bond as well to brackets. And so, the question was raised, well, what if we deprotonate the surface of these teeth first with 5.25% sodium hypochlorite prior to acid etching, and then bond, and then see if that increases or resolves this bond strength to the brackets. So they took 40 freshly extracted human mandibular first premolars with fluorosis, and they divided them into two groups. In group one, the teeth were acid etched as normal and bonded with composite. In group two, the teeth were deproteinized with 5.25% sodium hypochlorite prior to acid etching with the 37% phosphoric acid, and then they were bonded with composites. The samples were then subjected to shear bond tests by an Instron instrument, and then the sample from each group was selected for SEM study prior to bonding and analyzing etching patterns. And the deproteination using the 5.25% sodium hypochlorite prior to acid etching significantly increases the shear bond strength of the brackets bonded to fluorose teeth. So for any orthodontists we have, with us tonight, this is the results of the study were quite impressive, and this is very, very interesting because that's a challenge, and we see a lot of fluorosis in a lot of our communities because we didn't reduce our fluoride content in the drinking water, public drinking water, from 1 part per million down to 0.75 parts per million until about 3 years ago. So we still, we're still going to have a segment of our population as they go through the teenage years yet that are going to experience some, we're going to see with fluorosis, and it creates a challenge to bonding those brackets onto those teeth. This last study I'm going to share with you tonight, we're doing really well on time. Hopefully I haven't gone through this too fast, but it's a lot of material to cover in an hour. But this last one looked at denture cleaners. And I thought this was very interesting because the results of this I'm going to share with you because I use this in my practice as well. But this was a controlled clinical trial. It was randomized and double-blind and crossover. They took 64 denture wearers with and without candidiasis. So 24 of the patients had candidiasis and 40% or 40 out of the 60 did not. They were all instructed to brush 3 times a day, and they immersed their dentures in either for 20 minutes a day in different storage solutions. So they did 0.25 and 0.5% sodium hypochlorite, and in group 3 they did 10% ricinus communis, which is another denture cleaner, and then in group 4 they did just saline solution. The trial period for each group was 7 days, and then they did a washout of 7 days before they switched that person to another group and used a different solution. The 0.5 and 0.25% sodium hypochlorite were the most effective at reducing the biofilm and the bacterial counts on these dentures, and the 10% arc communis and 0.25% sodium hypochlorite were effective in biofilm removal, and they caused a remission of candidiasis, and they reduced the formation of microbial colonies on the denture surfaces. And all the solutions were tolerated and approved by the patients. So I think this is I think we see a couple of things in our practices these days. You see a lot of this in patients, a lot of candidiasis, particularly in your denture wearers. You see a lot of patients come in with burning mouth syndrome. At least I'm sure you do, because I do. And they have these non-specific symptoms, but they have this vague burning sensations or altered sensations in the mouth. More often than not, you're dealing with candidiasis when you see that, and typically, they have dry mouth, they have hyposalivation. Typically, it's secondary to not only age, but to medications that they're taking. And so one of the things that I put these patients on, I'll share with you anecdotally, I have them use off-label, I have them use the Carifree treatment rinse for a couple of weeks, and I've actually had better results, clinical results, using the treatment rinse than I've had using other antifungal agents, anti-agents in the mouth. So it's worked really well. And one of the things you have to understand about Candida albicans is that it's extremely aciduric. And so again, like most aciduric microbes, it's really well adapted to low pH. It is not capable or adapted to high pH at all. And so when you change the pH on these biofilms or the condition in the mouth, these microbes can't tolerate that. They cannot adapt to it. So taking a rinse that's 10.5 pH and just switching the pH on these biofilms produces some pretty good results. So I would share that with you. Anecdotally, for denture wearers, this study confirmed that. Completely eliminated candidiasis in all the patients using even just a 0.25% solution to soak their brush and soak their denture with 3 times a day, and then soaking it for 20 minutes. So that concludes, basically, that gives you kind of an update on current studies, kind of my history with sodium hypochlorite, and then kind of current studies that we use in dentistry, from caries to perio to endo to pedo, ortho, and actually even prosthetics on patients that have full dentures and candidiasis. And we do have a ongoing study at University of Washington looking at periimplantitis with sodium hypochlorite as an irrigant and a rinse. So I think I look forward to the day when we can share that data with you as well. So I want to really thank all of you tonight for sitting through this. I hope that you found this information interesting and that you took some tidbits back to your clinical practice that you can use tomorrow and have better comfort and knowledge on how we use sodium hypochlorite, how it acts, and what the indications and contraindications are when using it. So at the end of the day, it all comes down to a healthy balance, and that's what we're trying to achieve for our patients in their mouth, and it's what we're all trying to achieve in our lives in general. So thank you so much for spending this hour with me. And so, Nicole, I think we have time for a few questions tonight.
Yeah, I'm glad that we have some time left because we have quite a few good questions. So I picked a few of them. I know that you went over a little bit, some parts of them, but the first one is, so when eliminating all bacteria and combining it with an elevated pH, do you ever see an increase in fungal infections like thrush, or are there any other known side effects to using sodium hypochlorite for a long period of time?
That's a really good question, and I think we just talked about that a little bit, but let me go. That's a really good question. I know these questions come in during the program.
Yep.
So I've kind of answered that question, but let me go into it in just a little greater detail, because I think one of the concerns, and let me throw in another part to that as well, because one of the concerns when I first started using sodium hypochlorite was I was told that it's like, well, you're going to raise the pH, you're going to get a lot more calculus in the mouth. Like, that was a big concern. And I thought, I'm trying to put the fire out here. And so, you know what? If they get a little more calculus and they stop getting tooth decay, like, that's a trade-off I can live with, because I can clean that calculus off 4 times a year. And, that's a problem I'll accept, right? I'll trade that. Right. Interestingly enough, I didn't see that at all. In fact, the reverse was true. I saw less calculus form. And in fact, I even saw that on my own mouth. around an implant that I have when I started using it. So looking at a high pH, the reverse, so people had the expectation, oh, you're going to create more calculus. Well, actually it created less calculus. And then the question is, well, would it create more, yeast infection? Did it create more candidiasis? Is it going to create more problems there? And again, the same reality is true. Not only does it not create those issues, it actually tends to eliminate them. And for even the odd burning mouth syndrome that I can't really tie to candidiasis or anything else, people seem to find relief, again, by raising the pH and using the treatment rinse. So I use that sodium hypochlorite actually to treat those conditions. So and the reverse is true. It doesn't create the problem. It actually tends to solve it. So that's anecdotal. That's off label. But I'm sharing that with our listeners tonight.
And there was a question about using probiotics as well when you're using sodium hypochlorite for the 3 months, or using probiotics afterwards.
I haven't seen any research on that whatsoever. Oh, so let's go back to that question: was how long can you put a patient on sodium hypochlorite, and is that a problem? And I think that what we saw in terms of daily use or almost daily use in the study that we did in Queensland and Australia with the school children was you saw improvement for 2 continuous years, but from year 2 to year 3 there was no additional improvement. So it appeared to me in terms of dental caries that when I first started using it, I was looking for a knockout bitch. I figured you use this for 30 days and we've wiped it out and we're done. Everybody, crack the champagne, we're going to celebrate, and it didn't turn out to be that way. Altering biofilms and human behaviors is a much more Herculean task than I guess I envisioned, 20 years ago. But it's safe to use continuously for 2 years. Beyond 2 years, so this is on a daily basis, beyond 2 years doesn't really seem to have additional benefit. Now, when you look at Jorgen Slott's work in terms of periodontal therapy and in terms of, he's recommending it as a lifelong ongoing self-care as a rinse twice a week. So, I tell patients that, certainly periodontal patients, that we're using it to reduce, bacterial load for those patients, their plaque load and bleeding on probing. If we're using a sodium hypochlorite rinse for that, I tell the patients, use it for 1 week out of the month, which tends to be closer toward the Featherstone protocol with chlorhexidine, but I think they can use that for life. Based on the fact that it doesn't create any adverse effects or any persisters, they could probably use it daily for the rest of their lives without any significant problems. However, I don't know that that's really going to provide them with any additional benefit over, say, twice a week or maybe 1 week out of the month. And I try to structure programs for patients that's easy for them to remember. Like, tell somebody to, put this in your schedule and do it twice a week. Well, I'd have to program it into my phone with a reminder, because I'd forget. But if I know that that's just human behavior. But if I know I'm going to do it for the first week every month, that's something I can remember. And then, the first of the month rolls around and I use it for a week. That's a lot easier for me to remember. But I think that based on what I've seen in the literature and what I've experienced clinically, I think it's safe for patients to use long-term like that. And I have a lot of patients in my practice on it and a limited basis for really long-term for life. So
yeah,
I think it's
I know
safe.
A lot of us here like to use it continuously too. Makes your breath taste a lot better too. So that kind of leads us to the last question too. So how do I get my patients to overcome the taste of the rinse and to be compliant? That's probably one of the biggest questions we get all the time.
Okay.
How do you do it in your office?
Okay, so, and that's a really good question. And I have to tell you, when I first read, some of the work that Jorgen Slott was doing and recommending even before those papers got published, so this was like in 2002, I was done with chlorhexidine, I was done with povidone iodine, and so I thought, oh, this is interesting. I'm going to mix up a 0.25% solution of Clorox, and I'll rinse with it in the shower. And I did it one time. And I thought and literally, I was like, I'll never do that again. And I thought, I did that. I thought, I would never do that again. I mean, it was like, that was horrible. I would not do that again. In fact, the povidone iodine actually was less offensive to me than that. And I thought, so if I'm not going to do it, my patients aren't going to do it. And so that's when we started working on trying to figure out how do we create improve the taste of sodium hypochlorite. And apple, mint. I mean, we've worked on this for years to get the level of taste that we have today. But I think it's really about, like so many things in our practice, it's about creating the expectation for the patient ahead of time. And so to get somebody to be compliant on that, I like to, rather than send them home with a box and go, here's here's the instructions. You rinse it, you mix the two parts together, then you rinse with it, and rinse it out and spit it out in the sink. I think a lot of patients would do that one time and go, oh, never, that's horrible. I'm never doing that again. So instead, what we do in my practice is I like to have the hygienist or the assistant show them how to mix it and actually rinse with it in the office. And then I preface that with, this is going to be the worst tasting rinse you've ever tasted in your entire life. So I set up an expectation for them that this is going to taste really bad, but it's really going to help solve their problem. But be prepared, because this stuff tastes really bad. And the patients, generally, their response is, oh, it's not that bad. Like, because they're thinking, so they're immediately prepared for this, absolutely the worst thing they've ever tasted in their life. And then it's like, oh, yeah, it's not that bad. And that's typically the response is like, oh, doc, it's not that bad. Oh, it tastes like pool water, swimming pool water. It tastes, they always come back and go, it's not that bad. And then I have a lot of patients that go, oh, I really like that. And, I think they need help. But, we have those patients. So I think, like so many things in our practice, it's really about creating an expectation for the patient, kind of like overselling how bad it tastes and having them come back with, no, it's not that bad. And then they know how to mix it, and then I think they go home and I've had really good compliance with patients on the treatment rinse. And so, in fact, I have a lot of patients that ask me, can I use this every day for forever? And I'm like, yeah, if you want to. I mean, based on what we know about sodium hypochlorite, we believe that's safe. So anyway, that's how I handle my practice, and I'm happy to share that with people. But again, it's just expectations.
Yeah, I definitely think that works. I can speak to the offices that I've worked with that are successful. They say that they do the same thing. They set it up to be the worst tasting rinse they've ever tried, and then it's always better than what they expected. So,
yep.
All right. Well, I think that is all the questions we have. But I just want to thank you all, and thank you, Dr. Kutsch, for all the insight, and for everyone joining us tonight. So, any of the questions that we didn't get to, we will be answering them in the next few days. And then if there's part of the webinar you want to hear again or missed, we'll be sending out a recording. And then contact us if you want to schedule a one-on-one webinar to go over the Carifree system and products. So yeah, thank you again for joining us, and have a wonderful night, everyone.
Yeah, everybody. I don't take this lightly, and I really appreciate the hour that you spent with us. So everybody have a great week, and thank you again. Good night.